What is global health? Is it about the universal right to health as enshrined in the Constitution of the World Health Organization? Or is it about maintaining national and international security from the unchecked spread of dangerous diseases? For those of you with limited attention spans, who wish to get on with your lunches and tweets, I will now skip directly to the conclusion. Yes. As for the rest of you, let me explain. And to do so, I have to delve a bit into history because, as it's been said, if you don't know where you've been, you can't know where you're going. Over the centuries, the world has faced, in various forms, the push and pull of motivations as to why the well-off in one country should care about the poor in another. This dynamic has gone hand in hand with the expansion of global networks of trade and the movements of people. Now, this is a medical faculty and a health services faculty and students, so I'm assuming that, like myself, you have been trained in linear thinking. Symptoms, history, diagnosis, treatment, next patient. But we learn as we go on that patients, their families, their communities are far from linear, and history is like that too. So I start with a caveat. Breaking the tidal sweep of history into discrete blocks is, of course, an artifice, since complex systems don't permit such facile generalizations. But since I trained as a linear physician, I shall do so anyway. You must simply keep in mind that I will say is just a vague approximation of reality rather than truth itself. That said, let me describe what I view as the 5 eras of what we now refer to as global health, engagement with the health of people in other lands. First era was the era of quarantine and exclusion. This goes back time immemorial, but certainly the Middle Ages characterize these, the time of Black Death, of cholera epidemics. People lived in walled cities, and the approach to health from others was to close the gates and lock them out, to preserve what was inside to the best of our ability, and to let whatever was going on out there burn itself out outside our walls. To the extent that there was interaction, it was at times manifested in what could be called primitive applications of biological warfare. Bubonic cadavers were loaded onto trebuchets and flung across parapets to infect the residents of the walled cities who were trying to keep people out. Cadavers on trebuchets would perhaps be a good name for a rock band, so if that happens, I would like to receive a commission. Next came the era with which we are all very familiar, of colonialism and imperialism. This era itself had multiple stages and expressions, all very well known here in South Africa, with which I've been acquainting myself gradually of your history. 2 principal stages in the colonialism and imperialism era. What I would refer to as the extractive and supplantive stage, in which native populations were there to be enslaved or eradicated. We have long histories of this, certainly in my hemisphere, with the conquest of the Spanish, where in many instances entire population groups were wiped out to make room for settlers and farmers, and those few who were left impoverished and weakened were turned into slaves. Certainly the concept of health in that environment was not one that led to the benefit of those who were on the receiving end. And again, biological warfare, directly or indirectly, played a role in the spread of smallpox and measles, which in some areas of Latin America were estimated to have accounted for a 90% reduction in the population over the course of just a few decades. The second stage, or the second principal stage of the colonial and imperial period was the exploitive stage, where local populations were seen as a labor force resource, again at times through the processes of slavery, but also through other forms of forced labor or low-paid labor in order to contribute to the economic output of those colonies. And later in the exploitive stage came the growth of these countries or these colonies as markets for manufactured goods. This is particularly true in the British Empire, in which large parts of the empire, of the colonies, were places where British manufacturers were then sold in return for low-cost raw goods and supplies. Now, this is not a happy history, obviously, but it had some interesting consequences in terms of health. The health focus initially, as I said, was primarily on how to, as quickly as possible, reduce the health of the native population so as to subjugate them. And that was done through a variety of means. In the US case, many of the Native American populations were at times given wool blankets by the armies of the white colonialists, blankets that had been previously the wrappings of people who had died from smallpox. So thereby, again, primitive biological warfare was used to subjugate and wipe out native populations. But as the colonial experience grew in both its scope and its reach, the exploitive side became increasingly important, and there's an important element of exploitation of native populations, which is they have to be reasonably healthy in order to work and in order to purchase goods. So at that point, there started to become a focus on what we referred to at that point as tropical medicine, which is very much medicine of those people over there, rather than medicine for us. One of the great institutions in global health today, the London School of Tropical Medicine and Hygiene, was founded in 1899, at the time of Cecil Rhodes, as a way to improve, to work on the issues of health and healthcare for populations in the subject colonies. And obviously this was not entirely wrong or bad or exploitative. A great many good things have come out of LSTMH and other institutions that looked at issues of tropical medicine and hygiene, but we have to remember the roots of many of these activities. Hand in hand with colonialism came an associated but somewhat different trend. I'm not sure whether it can be called a different era or if it's an intertwined era, but evangelism became an important element of the interaction between the affluent countries, the colonial powers, and the colonies. Winning souls, rather than being extractive, is at its core redemptive and required a different approach to health and healthcare than the strictly colonial approach did. And out of this grew a very important trend in missionary medicine, which was driven, of course, by service to God. The concept of children of God is very closely tied to the idea of fundamental human rights. The right to health was never an explicit principle in this ideology, but it often was an unstated motivation of missionary medicine. And this too played a role in the growth of understanding of healthcare needs and healthcare provision to the underserved. But it was a complex relationship between evangelism and colonialism that muddied the waters a great deal up until this day in terms of the drivers of missionary medicine, as it might be called. This era persisted through the sweep of several centuries until the end of the great empires during World War II and shortly thereafter. And the next great era was that of ideological competition, or the Cold War, or anti-communism, if you want to put an ism behind each of these eras. This was the era in which development became the central organizing principle. And we mobilized around international health, as it was called then. I started my career in the midst of the Cold War with a great interest in international health. The central issues of international development were often built on, of course, the competition between the US and Western Europe on the one side and the Soviet bloc and China on the other. But the establishment of the United Nations in 1948 was a part of this sort of setting the structure and rules of the Cold War into place. And the Universal Declaration of Human Rights in 1948, as well as the World Health Organization Constitution, also in 1948, enshrined for the first time in international dialogue this concept of universal human rights and the right to health within the World Health Organization. Now, as we in the development community, in the international health community, looked at these issues, we focused initially and primarily on child and maternal health and on family planning. And clearly these were not enormous strategic issues in terms of the play of great powers, but they certainly did play a role in the great war of winning hearts and minds, which also underlay the establishment in the US of the Peace Corps and many other humanitarian developments that were carried out during the Cold War. It's interesting to note that family planning was, in its inception, strongly supported by the likes of President Richard Nixon. And the support for family planning can go back in some respects to some of the mindset from the earlier colonial period of trying to manage the demographics of low-income countries. But it evolved fairly quickly, along with the concepts of maternal and child health, into a fundamental issue of women's health, which saw some manifestation somewhat later that I'll describe as well. The dynamics of the Cold War they had two sides, and going back to my initial framing of health rights and health security, the World Health Organization in 1976 announced the Declaration of Health for All by the year 2000. We still hope to get there, but probably not by the year 2000, which was very much based on the right to health and community health and service in primary health care. On the flip side of that, not in contradiction, but another side of the approach to international health was the great campaign launched also in the 1970s that came to a successful conclusion in 1977 to eradicate smallpox. Interestingly, the smallpox eradication campaign was a manifestation of one of the few areas of intense cooperation between the United States and the Soviet Union. Both provided resources, both provided technical experts. It became something of a model of détente, ways in which the two great powers at the time were able to work together, and it was arguably the most successful public health campaign of history, succeeding in entirely eradicating smallpox virus from nature over the course of a relatively few years, with the declaration of eradication made in the year 1980. So we had international health as a way in which to help people, to show that we in the West cared about them and that they should therefore care about us and support us in the UN and the likes, but also a recognition that there were opportunities for constructive collaboration between, to put it politely, rival powers. So finally, on to our current era, globalization. The era of globalization can be said to start with the fall of the Soviet bloc between 1989 and 1991. But of course, globalization itself did not start in 1989. It started, I can give you the year, it started in 1519, the year that Magellan started his circumnavigation of the globe. The first time that anyone had actually viewed the globe as an entity. Big differences between 1519 and 1989. Those differences were differences of degree, of speed, and of permeability of national boundaries. Picture the boat that Magellan sailed on, or the boats that Magellan sailed on, and the Boeing 747, which became the great vehicle of globalization in the 1970s and 1980s before Airbus overtook them. So this speed of communications, of money, of goods, and of people came to drive the international dynamic that underlay much of what then took place in the health arena. The concept of global health itself, the word global health, I've looked into it. I have not been able to find a reference for the very first mention of global health, but I know that the first time that I heard the term global health was in the mid-1990s. So it fits in terms of this concept of globalization. It differed conceptually from international health in that it emphasized the transnational and the interdependent nature of health, and that it built the concept of health as a two-way street. You have to remember from those earlier stages, it was very, very much a one-way street. Either bad things were coming from there and we would keep them out, or we would help them, the benighted poor, to have better health because we would provide it to them. So that this concept of interdependence and a two-way street began to form a very different mindset about how you approach health across the world. Ironically, one of the great non-political achievements of the Cold War competition, which was totally removed from the international development effort, contributed to the concept or the mental image of a single interactive world, and that was the striking photograph of the Earth from space. The first time that humans had the opportunity not to see a hard model globe, but actually to see the world in which we lived and the degree to which these systems were intertwined. So there were two fundamental themes and drivers of global health that emerged during this time, going back well before the global health era, but given particular resonance by the forces of globalization. One was the right to health, and the other was health as a fundamental aspect of human security, of international security. Now, it's easy and very tempting to define these two themes in ways that are mutually exclusive and in fundamental conflict. But I don't see it that way. I've been involved in this arena for over 40 years at this point, and I'll do my best to explain why. Let me start my explanation with a quote from Martin Luther King. He said, "One of the greatest problems of history is that love and power are usually contrasted as polar opposites. Love is identified with a resignation of power, and power with a denial of love. What is needed is a realization that power without love is reckless and abusive, and love without power is sentimental and anemic. Power at its best is love implementing the demands of justice, and justice at its best is power correcting everything that stands against love." I think these are words that have resonated here in South Africa over the past several decades as well. So I will argue that rights and security are similarly necessary to one another. I believe that in a globalized world, the concept of a right to health is essential to each of the world's citizens. If health is not a right, it is a commodity for sale at the highest price to the auction bidder. So if the child of Kailechia does not have the right to get a decent standard of public health and health care, neither does my granddaughter. Oh, she may temporarily have that privilege for as long as we can afford it, at least, but it can be taken away at the blink of an eye by those with more power and those with more resources. The right to health is as important a consideration in the United States of Obamacare as it is for the realization of health in Mali or Malawi or Sierra Leone. So this is one way in which the globalization of principles, the concept of global unity, the oneness of the human family is essential not just for the health of those people out there, the poor, developing countries and so forth. It is essential for each citizen of every country. And it is what has driven the remarkable successes in global health, on children's health, and survival, and on women's rights to sexual and reproductive health. This focus on the right to health has driven our attention to the HIV/AIDS pandemic and its victims throughout the world, and in particular in sub-Saharan Africa, to malaria, to tuberculosis, and to the neglected diseases of the poor. It has also contributed directly to the emphasis on developing healthcare services for the world's least privileged communities. So this is an important and very robust trend in global health that has been driven by the concepts of globalization. Not least, of course, this is the moral imperative that drives and sustains most of us who work in the field of global health for what is at best a slow and tortuous task. But in a globalized world, health security has become an inescapable imperative. And like power, one that has brought important voices and resources to play in global health. When sailing ships took 2 weeks or 3 weeks or a month to traverse the oceans, outbreaks often burned themselves out before reaching ports of call. When we could leave Cape Town in the morning and arrive in New York in under 24 hours, the realities change. Most incubation times for most pathogens are well longer than that. And I speak from personal experience, having served both in government and in the NGO and advocacy sector, when I say that before the word security became part of the global health vocabulary, the likes of us, with apologies to Dean Womack, were relegated to the children's table. Allowed only access to the crumbs from the grown-ups table, the people who cared about the really important things, the threats to national and international security. That has fundamentally changed over the past 2 decades. Avian influenza, SARS, H9N1, and even fairly recently Ebola in West Africa have demonstrated to the world's powerful that neglect of health in the world's poorest parts can come at enormous cost to the world's wealthiest. SARS cost the country of Canada, when it infected people in Montreal, something on the order of $3 billion. It's been estimated that a global influenza pandemic could cost the global economy several $1 trillion. Now, when you're talking with B's and T's in today's economic world, people start to pay attention. M's no longer matter for much of anything. Enlightened self-interest is a very powerful force. On top of that, I mentioned several times the use of crude and primitive biological warfare in earlier eras. In the 1970s, biological warfare was outlawed internationally through an international treaty. The US had stocks of potential bioweapons. They were destroyed. Russia similarly had stocks. They were said to be destroyed. And we went through a period in which people thought, okay, we've put this genie in the bottle, and we don't need to worry about it anymore. We had several unhappy awakenings starting in the early 1990s after the fall of the Soviet Union and the release of information that had been kept very covert up until that time, that in fact the Soviet Union did continue to maintain a fairly robust biowarfare program up into its fall. But more troubling in today's world of non-state actors and terrorism, we are learning how easy it is to develop and to deploy agents of biological terror. We saw this in the United States shortly after 9/11 with the anthrax attack, and I would note that the use of biological weapons for terror has far more impact than the immediate health care impact. I believe there were 6 people who were killed as a result of the anthrax attacks in 2001. The cost to address and mitigate, not to say any further, not any indirect economic costs, came to the order of $3 billion in the US from 6 cases. That's a very high per case cost. We have seen similarly in other instances in which there were concerns. Now, this is not biowarfare, but the international transmission. Ebola, when it came to the US, stirred up an enormous panic. Transportation was shut down. People were denied entry. It was a huge public outcry, and all because of 2 active cases of Ebola that were imported into the US at objectively no significant threat to the US population, but public perception and the impact of the media was enormous. And of course, we now have the impact of social media, which is grown up greatly over the course of the past decade, where rumor and fear can be very rapidly and very effectively spread. So we know that this is potentially an effective weapon. We know that with the development of synthetic biology, it is now possible to recreate smallpox virus in the lab, to genetically modify other existing pathogens, to make them either more pathogenic or more resistant to the countermeasures that we have. So this is the sort of the dark side of the global health security side, is that there is a meaningful risk with potentially enormous consequences on both health and on economies. So this has gotten the national security and the international security communities very highly engaged and interested. And what's interesting and promising from our standpoint is the recognition that you cannot respond differentially to an intentional bioterrorism attack than you do from a natural outbreak that happens to spread. The way that we would deal with an Ebola from West Africa and a re-engineered smallpox virus from Afghanistan are largely the same, because it's a question of identification, rapid response, countermeasures. And what this means is that we've got at play here in the international health security, the global health security arena, a range of resources that we've never had before. From my standpoint, the good news is that in recent years, at least under the Obama administration in which I served, I think the current administration is more interested in building the walls so that the cadavers can't be thrown over. But this is not a political conversation. This dawning awareness manifested in the global health security agenda that I helped to craft in Washington when I was still there, has placed the emphasis not on building these higher walls to keep the threats out, but rather on working with increasing closeness with countries at risk to help them build their own robust health systems to prevent, detect, and respond to diseases locally before they spread nationally and before they spread internationally. This is, in fact, a dynamic that supports and reinforces the right to health. I see it as extraordinarily positive and an outgrowth that after leaving the US government, I went to work for the Norwegian Public Health Institute and worked with them on developing their global health security approach, again focused on building domestic health systems in low-income countries. It also provides opportunities for countries to work together collaboratively. I know South Africa has been quite constructively and actively engaged in the global health security agenda. It's a matter of shared risks and recognition that this is an arena in which no country, no matter how rich and powerful, can possibly go it alone. Furthermore, it increases the recognition of the need to address health in all policies, since this is not simply a matter of the healthcare system, but the way in which governments, military, civil institutions, the leadership of cities and of provinces and states, the way in which the police and the army and the water and sanitation sectors work together. So we're bringing together through this concept much more of a unified approach to health. We're at the early stages, we're not claiming success yet, but this is when you get a concept and can start to move it forward, that you have something to aim for. And it's also re-emphasized the importance of animal health. I don't know whether you have a veterinary school here, but Certainly the importance of zoonotic diseases that spread from animals to humans and then have potential for very serious onward spread. Certainly influenza is a case in point, but many others as well, not least HIV/AIDS. So this One Health approach is reinforced by an attention to global health security. Health security, tightly tied to the right to health, are in fact, I would consider them the yin and yang, for those of you familiar with Oriental Chinese iconography, those half circles that link together, the yin and yang of global health. We cannot address one without the other, and we cannot address the challenges to human health across the planet without addressing both. So, returning to the question that I started with, is global health fundamentally about the universal right to health, or is it about international security? The answer is yes. Thank you.